being in the hospital with anemia, being in the hospital with kidney failure, having a stroke. You know, it's like I'm only 52 years old. These are things that a 60-year-old gets. You know what I mean? So I have other friends that are over 50 that have been living with HIV for a long time, not necessarily around here, but like California, New Mexico. And they're saying the same things. They're getting the same things. So how has it changed? It's changed because I'm aging. You know, that's the biggest change in my life. Is, you know, every day it gets more and more difficult to walk. And I don't want a wheelchair. I have a wheelchair. I don't want a scooter. But I have to walk at my job. You know, I have to walk these long hallways because I work in a hospital. And so that's how it should. As far as treatment goes, I mean, treatments, it's never been better.
Yes.
I'm still amazed that I'm undetectable. You know, after a year of being on the same treatment, I'm still undetectable because a lot of times treatments fail. Like I just found out when I was in the hospital last year that I'm resistant to a whole class of drugs, which I had no idea about. There are a lot of side effects. Some they don't know about because they push drugs, you know, fast nowadays, and they haven't been around for years, so they don't know what the side effects are yet. But like the one drug that I was on, it contributed to my kidney failure. It contributed to the osteoporosis I have. But the exchange is you get to live longer. You know? The exchange is you probably won't have those diseases that people that died from AIDS when I was diagnosed did. You know, so that's the biggest change for me is getting older.
So you were talking about the side effects like the kidney failure, the osteoporosis. Is that more from the old AZT days, or is that, well, you said the newer medications haven't been around long enough to really know what the side effects are?
No, I have neuropathy that got started by the earlier medications, like the DDI and the DDC, and then diabetes made it worse. But no, the kidney failure and osteoporosis was actually caused by one of the newer medications. I mean, newer than AZT. You know, so yeah.
DDI, DDL.
Yeah, I know. T4T.
Right.
Yeah.
We've been through a long list.
Yeah.
And so, so the treatments are good. One of the latest campaigns is U equals U. Undetectable equals untransmittable. But mind you, the only research has been done on sexual transmission. They still don't know whether or not U equals U in needle sharing or breastfeeding.
I mean, I've heard that it can still be passed, you know, whether a woman's undetectable or not through breastfeeding. I've also heard that it can still be passed between every drug users because it's blood. It doesn't get rid of it, you know. And a lot of people, I still hear, oh, Magic Johnson's cured because he's undetectable. No, you know. But a lot of people think that that's the case, that if you become undetectable, it's gone. No, that's not the case. It just means that they can't pick it. It's too small to be picked up in a laboratory test. But it's still there. I mean, you're still going to test positive.
Yes, even the tests have gotten better because undetectable started out at 200, then it went down to 150, 50, and now it's down to 20, isn't it? 20, unable to detect 20 particles or fewer. So
that's awesome.
It is awesome. So that's the treatment for the person living with HIV. So you talked about Truvada, Truvada being a medication. So there's this whole new preventative Truvada is an HIV medication, has been given to people living with HIV, but it's also used as a preventative. So people that are consistently in higher risk situations and unable to change behaviors at the moment, or it may be simply, you know, what they call a serodiscordant couple. You may be positive, I may not be. And we want to reduce the chances of my becoming infected. So Truvada is a medication that is taken every single day at the same time.
Yeah, so you got to make sure your insurance covers it.
Yes.
Otherwise, it's
yeah,
really,
that's
really
a question.
expensive.
You have to also have a doctor willing to prescribe it, willing to monitor you, understand all the baseline tests that have to be conducted before, because again, you have to do the baseline HIV. Are you HIV positive already? If not, then testing liver, kidney functions, all of those kinds of things, and then monitoring that. You have to go to the doctor every 3 months, you know, and you have to maintain the regimen. You have to take it every day at the same time. And it's also used for what they call PEP, post-exposure prophylaxis. So that if you, I call it like the 28-day morning after pill. Because for like an occupational hazard where you may have a needle stick or something, or, you know, wake up, like I said, had that hookup on one of those sites. And then stumble to the bathroom the next morning and open the medicine cabinet. Why do people open other people's medicine cabinets? But, and discover HIV meds, I'm sorry. So, and it has to be done within 48 hours. Or 72.
I thought it was 72.
72. So within 72 hours, get to the doctor. And then it's a 28-day regimen of Truvada. Yep. And so it was just like when I had the needle stick about 20 years ago. The drug I took, the medication I took, was Combivir. And so it being tested in a drug facility of somebody who injected drugs, you know, pulling the needle out of their arm and being careless, I might add, and sticking it into my own arm. And so, again, fortunately, I had access to the best. Dr. Clausen was still around. And I went, and they did all the baseline tests. They talked to me, you know, and it was, of course, my decision. But prevention is in my brain, ingrained in my brain. And so I took the Combivir, but only for 2 weeks until that person's results came back. But let me tell you, it was an interesting experience. I'm still fearful today, you know, was there any residual kinds of side effects? But the whole time, it was kind of like, about a week into it, I would gag all the time. I mean, nothing ever came up, and it was just this gagging effect, you know. So was it psychological? Was it physical? I don't know. But yeah, so the person's results came back and they were negative, and I was like, but yeah, so the medications are there, and are very effective. And so where do we go from here? Treatment, knowing about treatments, knowing about the preventative aspects of the medications, U equals U. What else is there?
Well, I mean, one of the things that we cannot forget is the education piece of it. So even with all the new advances, and we're so excited to have these new advances, you know, just like when you think about the early days, you know, just to go through that timeline at the conference and reading through that history, it was like, man, we've come a long way. But the key to all of it is education. I mean, you know, we have to still be in the schools and talking with our youth about this. You know, have to make sure that people understand that if you are taking PrEP, that is the doctor going to be prescribing it? Right. So, it's not something you're, at least currently, where you can't just go into the, drugstore and get it over counter or anything like that. So we still have to make sure that we're educating our community about it. On all sectors, we have to make sure that we're talking about this. I mean, the church has to get involved into it. School has to get involved. Parents most definitely need to get involved with, talking with our youth about this and providing that education. And because I think for us, in regards to HIV, that fear is no longer there, as kind of what it was beforehand. And so because of, you're hearing about, oh, you could just take this pill to prevent you from getting infected, that, like I said, the fear is no longer there, but we still need to educate people that PrEP is not going to be for everybody. Let's be real about that. Everybody is not going to have access to it. So we need to make sure that we still are educating people about how to use condoms correctly. Make sure we're still educating people about, if they choose to, with abstinence as well too, but letting them know that there are all different methods that are out there to be able to help them in terms of protecting themselves. So it's like, I definitely say we still got to make sure we're doing that education piece and make sure we're educating people. But then also, allowing people to be educated about what actually is out there. I've always taken the position, I do that currently in my field that I'm in now, and even still in my field of HIV. My role is to educate you about what's all out there and for you to decide for yourself what's best for you. And so we definitely have to make sure that we're having that discussion, because even though, U equal U is an awesome and great, end game is where we want for people to be, but the point is you got to get there. You got to take that medication. You have to take it the way that it's prescribed. So there's still this whole education piece that has to be included in there. So I'm forever the advocate about education. That's why it kind of irked me a little bit about hearing how just the whole session of getting tested is changing, and how it's being more about the test, and getting those numbers and making sure, like one of the speakers at the conference talked about routine testing. And so I think back in the day, that probably would have been a good, conversation to have, and making sure, try to remove the stigma in regards to HIV testing. But today, we need to test people who really need to be getting tested. And so this blanketed testing, I don't know if I'm quite there, but definitely when you're talking about risk, categories, if you will, then definitely making sure that we are providing those services to them, but then also making sure during that session, that testing session, that we're going over what exactly is those risks, and why are you in here getting tested, and what's going to prevent you from coming back in here and having to get tested again. That piece is so important, going through using a condom correctly and making sure that that person who's in the room with you getting tested, that they know how to use that condom correctly, or the female condom or dental dams. So all of those kind of pieces, I still come back to education, because I just think that that's going to be so important. So where we go from here for me is still making sure we are educating people and making sure we are targeting the ones that we really need to be targeting.
But that's one of the fears that I have also, is this move to just test everybody. Routine testing, just like you go in for your blood work, they test your lymph nodes, all of those kinds of things. Again, I work with a lot of young people recently diagnosed, and they struggle with the diagnosis. No matter how good the treatments are, no matter how much knowledge they have, they still struggle with that diagnosis. Still struggle with, how do I tell my family? What will my friends think? What will my church members believe now about me? And so for me, that whole fear of moving to testing, when you even think about when you go to a healthcare provider, the limited amount of time that they spend teaching and educating about all health issues, the challenge that even many health providers have in screening people for things like substance use, and let alone sexual behaviors. Oh my goodness. Well, she looks like my grandmother. I can't talk to her about sex, or that's like a child. Why they shouldn't even be having sex in the first place. That's so people bring themselves to the party, and so that's my fear, because it is said that the Centers for Disease Control and Prevention is no longer funding the pre and post test counseling that goes with testing. They're just funding the testing. And so it's like you said, how do you know whether or not this person is ready to be tested? Because the move today is to get them